All right, at this time, if you wouldn't mind, take your seats. We have our panel coming up, social health. If our moderator from IHS CIO, Mitchell Thornbrew, could take his podium at this time, we'd like to turn this portion of the program over to Mitchell.
All right, good afternoon, everyone. That was a tough act to follow. So hope you guys are all energized and engaged after hearing those inspiring words. Yeah, just a great session to be in and to hear the kind of leadership that's happening across HHS and how it affects IHS. So I'm Mitch Thornbrew. I'm the Chief Information Officer for Indian Health Service, for those of you that I haven't met. It's great to be here with you. And today we're going to talk a panel about supporting resilient communities. So really excited to have a couple of guests here, but this panel is going to explore how IHS, tribal nations, and urban Indian organizations working independently and through partnership are addressing the social needs of American Indian and Alaska Native communities to build resilience, support workforce retention, and strengthen the delivery of culturally responsive care. And today I'm joined by Ms. Alicia Massot, the Vice President of the Oglala Sioux Tribe and Chair of the IHS Direct Services Tribal Advisory Committee. Give her a round. Thank you. I'm also joined by Ms. Melanie Forkiller, Director of Office of Self-Governance for Choctaw Nation. And I will join them in the seats here, and we'll start this roundtable and discussion. All right. We'll see if they fight for the mic here.
I already turned it over. So.
Oh, okay. They're too kind. So, in your experience, how do social and economic conditions such as housing, education, employment opportunities, and social connectedness shape patient health outcomes and influence the ability to recruit and retain a stable healthcare workforce in your community?
First of all, I want to say following the Secretary is a hard act to follow, so, but I'm glad to be here, and thanks for the question, Mitch. It was a mouthful. I think I'll address it in two parts. One is, first of all, how those, we call them social determinants or social and economic factors influence patient health outcomes, but then also how it influences how you recruit and retain a workforce in healthcare and in all of those health professions that you need to run your operation. We're located in southeast Oklahoma, about 13 counties. We have a hospital and 8 outpatient clinics, and then residential treatment and a host of other wellness and different types of programs that are also involved in our health system. So it's a big operation to staff and keep staffed. We're not located near an urban center. Our hospital is located in a town called Tallahena, Oklahoma, that has 1,100 people in it. So there's a lack of housing. The schools aren't the best in our communities. When you think about Oklahoma and you look at rankings, Oklahoma's typically at the bottom of almost every ranking there is, whether it's education, whether it's health status. And in our reservation, we have some of the highest poverty areas within Oklahoma. So you think about the lowest of the low almost in some of those communities that are suffering from a lack of employment, poverty, educational attainment, food deserts, you name it. And so we all know that what happens in front of a clinician or in a clinic or in your health system isn't the only factor that's going to translate into health outcomes. We know that if you have employment, if you have higher education attainment, that you typically have better access to health care, you have transportation, you have insurance, you have, different things that if you have a lack of those items, you don't have. if you have access to healthy foods, if you have easy access to good choices in your community, whether it's the ability to do physical exercise or whatnot, we know that all of that translates, all of that surrounds those families and communities and the environment that they're in translates to health outcomes. And I know everyone in this room knows those things, but so what I feel like is that tribes are uniquely in a position to address those, because we operate like governments. So we do housing, we do education, we do job placement and training. We work with the public school systems throughout the reservation to encourage, our students to get good grades, to study. We do those incentives to bolster those students' performance. So we have, hundreds and hundreds of strategies that we employ across the tribal government that factor into what a family, an individual, a community has access to support their ultimate goals, and which then translates into health outcomes. It does profoundly influence health outcomes. And there are those strategies and interventions that are very obvious, if you will, like the food desert situation. If people have easy access or easier access to food, then they're going to be healthier. I think that's a pretty straightforward outcome. What we also think about at the Choctaw Nation are those paths that are not so straightforward. For instance, we started a partnership with every public school within the Choctaw Nation to do a summer reading program. We employ the teachers at the schools for the summer. We utilize the public school facilities through a partnership, and we provide what's called a posse program. We call it a posse program. And so it's a summer reading program to lift up reading attainment for the students in those schools, and it's open to not only Native students, but any student from that school that wants to join for the summer. Because we all know students have friends, and more friends join, they're all part of the posse. So what we found after operating that program for years is that higher reading attainment translated into better health outcomes, which for me, I'm not a medical person by trade, but just the fact that you can read better means that you have healthier outcomes. Was pretty, it just, blew my mind, really, because I did not really connect the two. And so there are things that aren't so obvious that, we can do, and strategies we can take to influence that. So with that, I'm going to pause on workforce and give Alicia time to talk.
Thank you. First, I want to say happy 70th anniversary. This is a celebration. IHS has come a long, long ways, and I'm happy to be a part of this. And it's one of my favorites. It's one of my favorite groups to work with, because it's all of us, right? It's for us and by us, really, at this point. And so I always enjoy coming to the meetings and seeing all of our relatives from our different tribes, and really working together for the health and well-being of our communities and for our people. So I just want to say happy 70th to Indian Health Service. Looking forward to many, many more. And we've learned a lot along the way. I think I've been a part of this and the integral pieces of it for about 5 years now, and learned a lot. And in the beginning, it was a little bit of beating your head against the wall, but seeing a lot of progress is really hopeful. So I'm very excited to be a part of this. And some of the things that we've seen, even in my own personal life, I went to grad school at the University of Wyoming, and even the University of Wyoming, people were hesitant to go there for grad school. I'm a clinical psychologist by training. But it's always the community that makes the experience, and it makes it what it is, right? So if you have a good community, even in Laramie, Wyoming, I had a really good community there for grad school, and it made the experience what the best, and it gave me so much more to bring back to my community. And I would always be asked, where are you going after grad school? And I was always, I'm going home, because everybody was like, oh, I might get a, postdoc here, there, wherever. And people really didn't know where they were going. They were just going for the, whoever was the director or whatever. But for us, we always have that heart to return home for our people. And so I always think about, how do we integrate those people who don't know about the reservations or don't know about our communities? How do we bring them in? And we've had some really good providers who have come to our community and become a part of our community and become a part of who we are, and have stayed with us for a long time. And thinking about how do we build that more, and there's definitely a lot more we can do in our communities, and it takes us as tribal leaders, our communities, to build those as well. It's not just all on IHS, right? We have to work together. It's a trust and treaty responsibility that we have together. And so that's always something that I always take back is, how can we figure out how to make our people comfortable and a part of our community? And anywhere I go, if any of my friends, any of my other networks have, doctor friends or nurses or health provider partners, or I always ask them, like, do you want to come to Pine Ridge? Come visit us, right? Come visit us. And I actually had one of my Aspen Ascent fellows. Her wife works in our ER department now. She travels from Denver. Lois Liao comes to our ED now, and she's having an amazing experience. And I check on her. She calls me whenever she needs to, right? So it's those connections that we need to make too within our community, so that they feel comfortable, they feel a part of the community, they feel like they can have someone to call. There's a lot more infrastructure we need to build for childcare for non-Native folks in our communities. Even as much as a fitness center, right? A larger fitness center or place for them to go and work out and meet other community. Just finding ways to integrate them into our community, because we know our communities are rich and they have a lot to offer. But how do we open that up to our providers? Having a lot of contractors is hard, right? Because they come and go. But I'm really excited with this new hiring, this huge hiring push, so that we can figure out how we can really build those networks with our people, with the people coming in to do services in our communities, so that we can integrate them in and we can build the infrastructure. And like you said, housing is always huge, right? We don't even have enough housing for our own members. But how do we build that housing? And I'm happy to have those conversations. We had a great conversation at the Direct Service Tribes Advisory Committee on Monday about housing. We heard from Navajo, we heard from all the areas about what they think. And so I love the Direct Service Tribes Advisory Committee. We have a lot of input there. We have a lot of key leadership from IHS at those tables, and they take back notes. And so we're really looking at ways we can open up that communication between the tribes, between IHS, and how we can make that hiring happen together, because that's really what it needs to be. Because if you Google some of our communities, it's not the best, right? But like I said, we know our communities have so many strengths, and our ancestors fought for us to have direct service. So we're going to continue that fight, and IHS knows we always are ready to fight. But I'm really looking forward to, how do we work together? How do we fight this together to bring more providers in and create that social environment that we can all be a community together, community for our health and well-being of our people.
Amazing. Just the passion in your voices as you talk about all the activities and your perspectives, and we hear lots of things happen in a tribe to drive the community. We also hear partnership, and I love the story about how to bring people into our communities, because ultimately that's what we need. We need partners, and we need to bring them in, and I love talking about how do we make them more comfortable so that it's not scary or feels different, but it's what we know and the things that we love about our communities. How do we express those to people? So just amazing, but amazing to hear the passion that's going into this work. In what ways do the workforce stability or instability function as a social determinant of health for patients, families, and communities? So a little bit of a follow-up to these questions.
Yeah, so we've talked a little bit about housing. We've had to do a lot. You would think there's housing shortages in Oklahoma, that perhaps we're not that remote. But in a community of 1,100 people, it's either not desirable or it's just not there. And if you have health professionals that are making great wages come in, you need to be able to offer, places for families to live. Education, they're going to look up your schools and see how great your schools are. That's a challenge for us. In these small communities, our schools aren't necessarily great. Not to, downplay the hard work that educators do, but they're struggling with not having enough resources to provide a good school system. And these folks can probably afford private school for their kids if they were in an urban setting. So, you've got that, the access to grocery stores, even access to entertainment, access to shopping. You wouldn't think, but when someone's going to move their family to your community, the lack of those things really means something. And they don't move by themselves, right? Providers typically don't. They typically have a spouse that needs employment, so employing a person with their spouse is a strategy, but also, having enough employment in the community where that spouse can find a job when they move is important, because, they've all got to move as a unit. So, and if they don't, they're probably not going to stay very long. Yes. So you want them to be retained, so you want to be able to offer those things. You also have to be a good employer, and our tribal leadership really puts a huge emphasis on that we're going to be the employer of choice. If we're employing folks in the community, we want those folks that are needing employment to seek us out first. And they've really worked on that a lot, supporting employees, supporting all of the systems that support our associates with us, so that that's widely known that we're an employer of choice. Come see us. And another strategy is our residency, of course, and that gets our graduate medical residency program. And what that does, we have 15 accredited slots for that, even though we're in a very rural area. And that gets those folks the experience with us, so they get to see what kind of employer we are. They get that experience with us. They get this, know their colleagues, potential colleagues, right? That they, if we ultimately hire them, 70% of those residents end up working for us. And then another 10% end up working in rural healthcare still. So that still benefits us, of course. That supports rural healthcare outside our system, but within the reservation oftentimes. So those are great numbers. It's been by far the best recruitment retention tool we have, because even doctors that have not been part of our residency will seek us out, just be part of the faculty, because they want to be part of a teaching health center. So they'll seek us out for that reason. And it really raises the overall quality of the healthcare, because it keeps everyone on the modern, what's going on right now in healthcare, because they're having to keep up with it for the residents. So it really raises the overall quality for the entire system and the faculty. So it's been very successful there. So those are some things that we face, although the residency has created this pipeline that has allowed us to overcome many of those obstacles. Housing, we just had to build it. And we got a few ancient, and I think they were like 1930s era quarters from IHS when we took over in 1995. And so we've had to add substantially to that. We've also had to add a hospitality home for patients, because there was no place to stay for families when they came, with their loved one to the hospital. So all of those things are part of, just an overall system to be able to keep folks with you. And the longer you can keep folks with you, the better patient relationships are with those providers. They get to know them, they get to trust them, and they'll be, they'll come back. They won't delay coming back, because they're getting a different provider every time they come back and see a doc. So it's just an overall better experience.
So on the issue of instability and stability of workforce, our community's tough, right? We'll hear from Tribal Council, will hear from our constituents. We talk amongst ourselves, right? Who gets the providers, who are their providers, right? Who are the good ones? And then why can't they see the same provider over and over? Why is there such inconsistency? And so our community knows that because they're not being tracked by the same person. You know, they have to tell their story over and over every time they go in. And also, it creates a burden for our workforce in the IHS. I know our service unit in Pine Ridge, they do multiple things, right? Our CEO is a pediatrician. She'll go down and do some pediatrician every now and again, you know, work with the kids. And so it can create burnout, and then we start to lose more and more, right? So we definitely need to look at that because that is a huge problem, that instability. And we know on our end we have to do the work in our communities to create that community for them to be a part of. I'm really excited that we're all going to be on the same page of doing that now. And the housing is a huge issue, but it just has such a huge impact when you have people coming in and going. I know, you know, that you have to know the community you're in too, right? You have to know the history of that community. I think knowing that history really does help people be better providers. They know, you know, going all the way back, the history of where the treaties came from too. It's a rich, rich history, and that can help them stay. But the contracts is a huge issue, and so we don't see the same provider all the time. We are looking to hire more, so I'm really, really excited for that huge hiring push and to see how we can work together to get more people in, so our people can see the same providers, we can integrate them into our communities, and that we can provide the best health care.
Yeah, excellent highlights on the challenges of you know, having that stable workforce. And so building on that, how does turnover affect the care, as you talked about, but also the trust of your patients? You guys talk a little more about that?
I think I pretty much touched on it, but again, it is, I think, as Alicia said, you know, having to explain your conditions over and over and over again. New doctor getting to know you, getting to know what they're treating you for, and just medical compliance, you know, that, you know, do they really want to come back as often as they should when they're not going to see the doctor they've gotten to know? And so all of that factors in, I think, and probably other things as a matter of trust. Trust not only in a physician or a provider of some type, but trust in our system that we can't keep that steady pipeline of folks. Before GME, and we had a more steady pipeline coming in, and we didn't have as much stability, we were shifting, even in a large system, we were shifting folks around. Right? We're short in this clinic, so for this week, you know, you're going over here and you're covering, you know, over here in this clinic, and you're covering over here in the hospital, and you're, you know, so bouncing folks around even inside the system creates that instability and less trust by our patients.
One thing also I wanted to touch on is we talked about communicating from IHS to the tribes, but also amongst our IHS facilities, right? Not just direct service, but to our contracted and compacted IHSs, because we always send our patients to a non-native facility, right? So if we can create that communication amongst all of our IHSs, compacted, contracted, direct service, then our people will get to know those other providers in tribal communities, right? And then we'll circulate that money within our own services as well, creating that trust even amongst our own service units, and whether, like I said, compacted, contracted, or direct service. I'm really excited to open up that communication because we are the 18th largest health service in the nation. And why aren't we using each other? Why aren't we collaborating across our health units to provide services, especially if we're going to create this amazing health care for tribal people? Who else would better do that than our own IHSs? I do want to touch on and thank former Director So. She did a lot of work. We've had some, and I used to talk about this a bunch and beat it to death, but we did have some bad actors in IHS who would get promoted. We've experienced that directly in Pine Ridge, right? And we're still seeing those impacts in our community. But Director So made some huge efforts, and I know IHS internally is making those huge efforts because we do have a lot of vulnerable populations and vulnerable communities. And so we do need to learn how to weed out those bad actors and not keep them in, not promote them. And there have been some big efforts to do that, and I truly, truly appreciate that. Like I said, I was beating that very loudly when I first came to this because we were having those direct impacts in our community. But that's one thing also that we need to do to build that trust, is to ensure our communities that, yes, we are going to protect you. Yes, we are going to put these safeguards in place if there are bad actors, and we're not going to promote them and allow them to stay in the system. We're going to tag them quickly, and we're going to take appropriate action so that we protect the community, because it is social health, right? Like I said, those impacts are still in our community. And so just wanted to note that. I know it's a celebration and we are moving forward, like I said, but we do have some lessons learned, and IHS has learned from them, and they are moving forward, so I'm thankful for that.
Yeah, great conversations about trust and, the obligation. We talk about building trust with patients, building trust with providers, being that employer that they want to work for, having good insurance, having good support, all the things that people expect. And then our patients, that continuity, not explaining themselves. That one hit home because I've had to do that a couple of times recently. And you're like, I got to go through the whole spiel again. But that's really important. And then also, we can't shy away from what happens when we lose that trust. And so we should look to those examples of why this is important. It's important for our patients, our providers, our communities, because when we lose that trust, we have seen how damaging that can be for years to recover from that. And again, happy to work with our IHS and tribal colleagues to just really confront those challenges and do the training and bring the awareness to make sure that we're fulfilling our obligations and we're building those communities and trust. So I know we've talked a lot about it, so we may not have much more to add here, but just that long-term presence. I know you talked about training and education. There's a lot of research that says the things that you're doing result in a pipeline to rural communities. When doctors, nurses, and professionals train in our rural communities, sometimes they marry folks from our communities. That's great. They're anchored. But having that experience in a low-risk environment raises their comfort level, and whether they stay with us or they go to your rural communities, it creates that pipeline. I love that you pointed out. Even if they don't stay right where you trained them, you recognize they're going somewhere to some other rural community, and that's a benefit to us all. Also, the velocity of money. Talking about the impact that we have as employers, the businesses that tribes drive, even just operating the health systems. In many cases, we're the primary, we're the highest paying employer in a lot of our communities. And so, how does that work for building that long-term workforce presence in the community?
Well, I think we have kind of touched on this, but I think having your workforce stay not months but years, and they become friends and very familiar with the patient population, whether they're directly serving them or not. They're in the community. They're joining community events and efforts in their community, so they become a fixture of the community. And so as trust becomes built, then healthcare becomes less transactional, right? It becomes part of a relationship with the patient, rather than just you're coming in for the XYZ and I may never see you again. So that's it. It's as trust is built, then it becomes more of a two-way relationship.
So anytime I talk to a group that comes to the res and they're there for work or whatever, I always let them know, feel free to go out in the community by yourself. You don't have to go out in packs, right? Because whenever I go, whenever any of our community members go and leave the reservation, right, we are a minority. on our reservation, for us, we're the majority, so we're comfortable going anywhere, right? But when we're off the res and we're a minority, it's hard, right? And when these people come to our communities, they're a minority. And it's very hard for some people to be a minority who aren't used to being a minority. So it's just giving that encouragement and really reflecting back to them, like, this is how we feel, this is how our students feel when they go to college, right? Like, they feel that. So embrace it, because then you'll be able to relate to them better. You'll be able to understand their experience when they leave the reservation. So just try to go out by yourself. You'll be fine, you know, and don't pack up, because we see you packs going around. And that's how we notice people in the community when they go around, and, you know, people get to recognize them and get comfortable with them. But I think understanding that how we feel as a minority, and even if they're not a minority, you know, generally, when they come to our community, just trying to understand what that feeling is, so that they can relate to us and try to become a part of us too, right? And try to say, oh no, I'm going to try to go out and, you know, meet more people and go to these different events in the community. So I always try to think about it like that and convey that to them, so that they can learn their own insecurities, right? And also try to figure out how they can help build that trust too amongst the community and with their group that they're there with. So,
yeah, absolutely. I know we're circling a lot of these common topics, but I want to dive in and talk more about sustainability of some of those programs and how you see and what are the challenges around that sustainability. And you've already talked a lot about examples where you've seen community-led, cross-sector approaches, whether that's the tribal government and education, housing has been a big one, the workforce that we've been talking about, and just healthcare in general. But those things that have strengthened the social health and the workforce retention, what are the challenges around sustainability?
Well, I'm going to speak to GME for one. We started it with a HRSA Teaching Health Center grant. Those are competitive, and they don't fund everything you need for a rural GME program. You know, they'll defray your costs, but it's not necessarily recurring to you. That program can stop. Congress can not renew it, or you may not get a future grant. So that creates its own instability. We have to go back and fight for it each time. But I will say, you know, through partnerships, we partner with Oklahoma State University on that program, because they focus a lot on rural health care in Oklahoma. And so through that, we've become accredited. Now Cherokee Nation has its medical school, so that creates another opportunity for more Native students to graduate from medical school that we can recruit as residents. So just one more place to recruit from, which we love, because sometimes we have to recruit from out of state to get those residents to come to us. So the challenges with rural GME are that one, you know, our hospital doesn't have a ICU, for instance. You know, there are fields or areas of practice that we just simply don't have in our system. We've got to send that resident to another facility outside our system to get those resident experiences that they need in order to fulfill their program. We've got to pay for their travel, we pay for their food. We also pay an enhanced amount per student for their stipend to get them to come to us. We have to build housing for them in Tallahena because, again, no housing or lack of housing to have all those students. And then, you know, so for a rural GME to be successful, and I know there were several in Oklahoma that just folded because you know, they just couldn't support it. Tribes are in a position to be able to, you know, reprogram funds and do some things that, you know, say just a municipal hospital can't, you know, in a small town. So they just can't operate those in rural areas. So, but it's been by far the highest successful tool that we've had. We've also used, you know, loan repayment and the scholarship program to try to attract those health professionals. I will say loan repayment has not kept pace with loans at all. We've had to move forward on our own and either enhance those or expand them to include additional health professionals, because there are just simply not enough of them, and there are not enough of a defrayment of their outstanding debt. So those are all challenges to us. So we just keep moving ahead with that, but we are now seeing the benefits of those years and years of investing in that.
So I will say I'm really hopeful for sustainability. We know tribes are never fully funded, right? So we always have to think outside the box on all the issues. And so I'm really hopeful for sustainability now that IHS is on board with this big hiring push, because now we can put together our minds and see what we can do together to bring people in, because there's a lot of other ways we can do it. But I think to the point of housing and other things and finding funding for that, like I said, we're never fully funded, and we always have to look for grants, and those are 5 years and things like that. But
Competitive.
Yeah, competitive, right? And that's supposed to fill the gap, but it's still competitive, right? But those things are. I lost my train of thought. No. We're just never fully funded. So to think about how we can do this together to create sustainability, I think with IHS on board and trying to figure out how we can do that, I think we have more chances of bringing people in. Philanthropic money, right? 0.04% of philanthropic money goes to tribes and tribal communities and Indians. That's not enough. So we need to tap the philanthropic network too to figure that out. And we know doctors have connections. Medical people have connections, right? So if we're bringing more of those people into our communities, then we can figure out those other networks too, right? And they can connect to our communities, so we can figure out how to bring those other types of funding in that aren't necessarily from housing or from these other departments. Shoot, my thought came back and then I lost it again.
It's slippery thought.
Oh, no, the loan repayment. Loan repayment. So we also know the departments there's kind of siloed, right? And we know we have to pay taxes on our loan repayment. IHS does, but VA doesn't. And so that's not IHS, that's the Treasury, right? So we have our treasurers on the Treasury TAC. And so she took that issue there, too. So it's us as tribal leaders, too, hitting up all these different departments, connecting the dots for them as well, and letting them know, Treasury know, we need to take the taxes off of the IHS loan. So that's our job, too, right, as tribal leaders, is to let the different departments know what they can do that could help IHS, could help these programs, and help for better sustainability. So sorry I went all over, but.
No, that's great.
It's the light.
One last question, and I do think we'll have a few minutes to make sure that if there's any key talking points, questions we missed, we want to hear from you. This has been a great conversation. But looking ahead, and this is a little bit of a segue there, what investments or policy shifts would most strengthen the local workforce and economic foundation needed for healthier communities?
Well, I've mentioned some of it, but if there were reliable, consistent, recurring funding for GME, that would be incredible. That would fund the costs of GME in a rural area. Loan repayment taxes, that's an issue not only for the IHS program, but for tribal programs, because tribes are embarking on their own programs to do loan repayment, and those have to be taxed. Tax incentives for providers that are practicing in workforce shortage areas. I mean, why not? Another recruitment tool to be able to get them to your community. And then stability of telehealth reimbursement. It's kind of been, COVID did a lot of things for us. We saw the benefits of it. We could see the benefits of, building out specialties and that sort of thing with telehealth. And then, every so often it's like, well, these are going to expire. We got to rush around and get them renewed, especially from Medicare. But, from state to state, Medicaid varies as well. So getting some stability for telehealth reimbursement.
So as a tribal government, we make our own laws, right? And so we've made and resolutions, right? So we did a resolution of support for the workforce in Pine Ridge that are non-native to use our own facility for their health care. So they don't have to leave for a whole day, take a whole day off, and go to get their health care needs somewhere else, right? They can use our own, where they work. They can go and they get billed, right? So they don't have to take a whole day off either, because it is a whole day to get to another provider where we live. So we can do those things as well. So I'm really excited to think more about those things and collaborating with our local Indian Health Service. I actually talked to Dr. Jumpingo about that one. She came up with that one, so we pushed it forward, right? So even having more of those conversations with our local IHS or areas to figure out what we can do too, tribally, for our laws and our resolutions and the things we support, and then push those on to IHS or other departments to help, create those better avenues for our healthcare providers. So that's always something I always think about first, is what can we do tribally? Because sometimes when we wait for other policies to happen, we better not hold our breath, right? And so I always think, what can we do quickly with our own tribal government and get support? Because we do support our local healthcare providers, all of that. So it's going to help me think more outside the box of how can we create more policies locally at home that we can support healthcare providers with this new influx of hiring.
Amazing. And just as we get to the end here, I want to make sure that anything that we didn't ask, like a question that we didn't ask, or answers or thoughts that you wanted to share on this topic.
I don't know that I have any other than to just generally say how pleased I am to be here to help celebrate. We've come a long way in 70 years. We've got a long way to go to get to where we want to be. But we've certainly made some great strides, and I just appreciate the partnership that we have with IHS.
Yeah, no, I just want to thank all y'all here in the room and all of the IHS employees, those who are on the ground providing services every day. It is our trust and treaty responsibility to work together, and I'm happy to be a part of that and happy to continue moving us forward together so that we can get the best health care for our people.
Well, it's been an amazing conversation about a topic I think everybody in the room, regardless of what your background is, this touches on our families and things that we feel as patients and that we know intrinsically as leaders in our communities and agencies that we have to address. So I want to thank you for all of your ideas, your thoughts, your openness and sharing, and again, recognizing your passion for the work that you do. It's amazing. And just can I get another round of applause for Ms. Masso and Ms. Forkiller? All right. Thank you very much.
Produced by the U.S. Department of Health and Human Services.